Takano, and I'm here at the Inland Empire Health Plan building. Actually, it's in San Bernardino County in San Bernardino, but the IHP serves both Riverside and San Bernardino counties, so I'm here with Dr. Bradley Gilbert, who is the Chief Executive Officer of the Inland Empire Health Plan. And Dr. Gilbert, thank you for joining me today. As you know, I'm wanting to get accurate information out to the public about the healthcare reform proposals, the repeal and replace legislation that's being debated and considered in Washington, and to get real accurate information about how that would impact us here in California and specifically our two counties. So why don't we just start about telling people about IHP. When I got here, I was stunned at the size of the building, but then I began to think about how many people you must serve. So how many people does IHP serve, would you say?
Well, thank you first for having me, Congressman. Really appreciate the opportunity. Yeah. So we serve 1.25 million people in the Inland Empire.
Wow, 1.25. That's about 1/4 of the population here.
It's a little over 1/4.
And that's Riverside and San Bernardino counties
combined.
So we're about 5 million people between the two counties. So 1/4 is about 1.25 million people. And now before there was this expanded Medicaid, and we can use Medicaid and Medi-Cal, those words interchangeably. In California, the Medicaid program is known as Medi-Cal, and that's because the state and the federal government share the responsibility for how we fund medical care for folks. Just tell me about the population. So we got 1.25 million people that this agency, or this actually, it's a nonprofit, kind of like a provider, nonprofit provider. That's what you are. You sort of manage the care of these 1.25 million. Tell me roughly the breakdown of that 1.25 million.
So a very small number have both Medicare and Medi-Cal. We call them Medi-Medis or duals. That's about 24,000. All of the remaining are Medi-Cal members, but they're in different groups. So one of the most important is the group that was covered under the new ACA, which is the expansion population. And that's about 340,000 of that 1.2+ million. The rest are individuals that are families with children, or seniors, poor seniors, low-income seniors, and individuals with disabilities.
So about, you said 330,000?
340,000.
340,000 of that 1.25 million are that number represents the expanded Medi-Cal or expanded Medicaid. So under the Affordable Care Act, the numbers of people who could be on Medi-Cal was expanded. So beyond those folks that are disabled, beyond those folks that have low-income folks that have children.
Right.
So it's basically adults. Now, you and I have talked about how it's not quite accurate to say that all these folks are able-bodied adults who are not working, because of the 340,000 people who are on expanded Medi-Cal, you're telling me that according to your estimates, it's about 60% of that population is actually working.
Yeah, there's probably 65% that are working. There's another 20% that are looking for work. And the other thing I don't like about able-bodied adults is that many of them have pretty significant chronic illness. Thousands of diabetics, thousands of individuals with asthma, hypertension, heart disease. So these were adults that previously had no coverage at all, that were now covered under the expanded Medi-Cal eligibility. So they're adults, men and women, and many of them have pretty significant chronic illness.
So managing diabetes, for example, without medical coverage is expensive. People might be going without their medications. There's all different levels of severity of diabetes, from people who need to take insulin daily to people who just need to take some medication if they're sort of pre-diabetic. And I've known some friends who are trying to manage diabetes, And there's all sorts of sort of mental conditions that go with that. People, their blood sugar goes up and down, their mental health, they can be depressed. So trying to find work while your diabetes is not managed well is an extra kind of burden.
No,
So,
exactly. I mean, if you think about it, they can't afford medications, so their diabetes will not be in control. They get depressed, they get heart disease, they get kidney disease. So if you don't care for them, if you don't organize that care, they get sicker. They'll end up costing the system way more money. And if they're not covered, they're still going to show up in the emergency room and get admitted to the hospital, but they have no coverage. So meaning that means the hospital has bad debt. They don't get any reimbursement for that patient. And that ends up costing us all money.
So pre-Affordable Care Act, this 340,000 group, this population of 340,000 that existed between Riverside and San Bernardino counties, they would have had no medical care at all. I mean, I think it's safe to say that a big chunk of them were having a difficult time managing their health conditions, and you don't manage those conditions like diabetes, it gets worse and worse and worse until you have to go to the emergency room. And then that affects those of us who do have insurance, because the emergency room then has to administer care that's far more costly for conditions that might have been prevented or slowed down had we managed that care, had they had access to care.
Right. Well, not only that, but the hospital gets no reimbursement for that patient. So what happens is, prior to the ACA, or before 2014, the self-pay, as they call it euphemistically, which is really no pay, was about 17 to 20% in our hospital ERs. Now it's down to 6 or 7%. Well, what the hospital has to do, if they can't get reimbursement from those patients, is they have to charge other patients more, which is individuals that have commercial coverage.
Hold on, we're doing Facebook Live. I just want to make sure if the folks, I want to make sure they can hear us talking, because we're doing this with an iPhone. So I just want to make sure if you can't hear us, just type a comment, tell us that the sound needs to go up. But Dr. Gilbert, you're saying that you were telling me before we got on live, that prior to the ACA, that the debt, the unpaid debt owed to emergency rooms from people who had low incomes, they would come in with their very serious conditions, couldn't pay, and that was charged off as debt. Because in this country, we just don't, we have laws that just say you can't just deny people care when they come to the emergency room. We're not a kind of country that says, well, you don't have insurance, too bad.
No, they have to treat you.
They have to treat you by law.
And they have to admit you if you need to be admitted.
Right.
To the hospital.
So you're saying that, you quoted me a startling statistic. Before the ACA, the hospitals, whether it was Parkview, a private nonprofit hospital, or community hospital, or the county hospital, their emergency rooms had to take
anybody who comes in the door.
And they could charge the patient, but they couldn't collect on it. They couldn't pay that. They couldn't pay that, and often that would amount to tens of thousands of dollars for some people.
Right.
But it was not paid for. Can you describe the level of debt then that hospitals are experiencing, and the level of debt now?
It was probably 17 to 20%. So 1 out of every 5 or so patients that came in couldn't pay them. Now it's about 6 or 7%. So that's the real, if you think about the risk, if they change the expansion or they change Medicaid, Medi-Cal in California, think about the dollars that are not then available to the hospital. We have at least 2 hospitals in our 2 counties that could potentially go under if they didn't have that additional reimbursement that's coming from Medi-Cal.
2 hospitals that could just close their doors because the business model would just totally be unsustainable. Unsustainable because now they're actually getting payment, but So
they do a lot of Medi-Cal. These are hospitals that do a lot of Medi-Cal business, a lot of my business, and we pay them. So they get paid by us for any of our members that come into the ER or get admitted.
Well, you're telling, these statistics go, but in general they all kind of, I think, resemble each other. I recall that our uninsured rate in Riverside and San Bernardino counties was around in the 20s, 21, 22%. And you're saying it's down now to 6 or 7%?
So you've had this dramatic decrease, and it's all because of those. And remember, it's not just IEHP. You also have the individuals that are in the exchange. That's probably another 150,000. You've got probably another 60,000 in Molina. So you're talking 550,000 people that got covered.
So IEHP, so of the total Medicaid or Medi-Cal population, IHP has about almost 90%.
About 90%. Yeah.
Molina, which is the private managed care operation, that is kind of what you call your competitor.
Right.
They have about 10%.
10 or 11%. Yeah.
Okay, so we're just talking about the people who the organizations that manage the Medi-Cal patients. Yeah. The Affordable Care Act also, of course, helped a lot of folks who earn more than 133% of the federal poverty level wages.
Right.
Let's translate what that means.
Yeah, because I think
let's translate that to me.
Yeah, because I think people don't understand how low of an income it is. Yeah. So at 133% of the federal poverty level, that's about $16,000 a year for an individual. So full time, that would be an $8 an hour job. So these are very low income people.
So. Wow, $16,000 for a single person. So if you earn below that amount, you can qualify for Medi-Cal. People who earn above that have to either have an employer that provides them with insurance, and in many cases, our employers don't do that.
Correct.
So then they would have the option to go and buy a private policy from the exchanges.
Through the exchanges
with a subsidy.
With a subsidy, depending on your income level.
And that's a sliding scale.
It's a sliding scale.
All right. Now, what's important to know is that the House of Representatives passed a bill that really made that sliding scale a lot less generous.
Right.
And really, for these folks above $16,000, you think about how much they pay for rent, how much they pay for food. Very little left over for buying a healthcare policy. So the subsidies, they make it possible, but it's still expensive for those folks. But nevertheless, we've also whittled away at that 20% uninsured rate by also having pretty generous subsidies to enable our folks who are above the $16,000 single person earnings.
So of that 150,000 in our two counties that got coverage through the exchange, 80% are subsidized.
80% of them are subsidized.
Yes.
Wow.
Yeah.
Wow.
So to your point, it's between the expansion of Medicaid and the subsidized exchange that people have gotten coverage. And as you noted, the House bill changes those subsidies, and they're not as generous, which so means people may not be able to afford. And of course, they change Medicaid expansion dramatically.
So, with uninsured people increasing back up above the 20% level, we know the Congressional Budget Office on the Senate bill, not the House bill, said that 15 million or so would lose their insurance system within the first year. We can kind of see how this would put at least a couple of our hospitals here in Riverside County really on the brink. And that will definitely affect those of us here who have jobs that provide us with decent insurance. Those hospitals have to pay for, they don't get paid, so they're stuck with all these bad debts that they can't collect on. And that really hurts the doctors and it hurts the hospitals, but ultimately it's going to mean that our costs are going to rise.
Yeah.
The employers, our employers who buy insurance, are going to experience bigger premiums, and that's going to impact how much take-home pay we have and all that.
So just to give you a sense of the order of magnitude of the dollars, just IEHP for those 340,000 members, it's $1 billion into the economy. $1 billion of payments to hospitals, doctors, and pharmacies. So you pull that $1 billion out, that's going to have a major negative impact on the economy. The doctors, the pharmacies, the hospitals, they've lost $1 billion of revenue.
So that's $1 billion coming into our local economy that's supporting our medical infrastructure.
Correct.
Medical infrastructure that all of us benefit from. All of us use it.
Right.
And so, wow, that's an incredible thing to contemplate, really.
Yeah.
So Now, really, I want to use your expertise because you're here to talk about. I mean, you're basically someone the expert on how you administer Medi-Cal, and I noticed that also you say that you also are responsible for the long-term care of our seniors.
Yeah.
So let's be clear that Medicaid is not just about low-income families. It's also about low-income senior citizens. A lot of them also have Social Security, but people don't realize how much Medicaid and Medi-Cal fund long-term care for our seniors.
Most of the people in long-term care facilities are covered by Medicaid and Medi-Cal. So we have about 3,500 individuals that are in long-term care. But the nice thing is when you're in a system of care that's organized, is we can help them get home safely, well protected with in-home supportive services, with nurse home visits as needed. And so you get them out of the facility, which is an expensive place to be and not always the nicest place to be, and you get them back to their homes. And that's lower cost, it's better for the person, but you can only do that if they have the coverage and they're in an organized system of care.
So I've heard from doctors that they can't really accept Medi-Cal patients because the reimbursements are too low, but that's why IHP was created, right, was to find out where we could find savings. And one of the ways that you find savings by managing the 1.25 million people who are on Medi-Cal here in the two-county area is you try to get people out of long-term care safely. You're not shoving them out the door.
No.
You're not shoving them out the door.
No.
But people generally prefer to stay in their homes, to be cared for even by family members that are caregivers. And we have programs to support
to pay
them.
for that. Right.
People complain it's not enough, and that's another debate.
Right.
But it's interesting because you are able to kind of save dollars there, and then that allows you to make sure that the other Medicaid or Medi-Cal population has access to specialists and other healthcare needs.
No, exactly. So by keeping people out of the hospital, keeping them healthier, by being able to get people out of long-term care facilities back to their home, that allows me to have dollars to pay doctors better. So I can have the specialists that we need, again, to prevent them from going in the hospital. So if you've got someone with serious heart problems, they need to be seeing a cardiologist on a regular basis. Well, I have to have a network that, I have to have doctors that will see them. The way I do that is I pay better than Medi-Cal. So I use the dollars saved from the inpatient and the long-term care to pay doctors better, so I keep people healthier so they don't go back in the hospital. I mean, it works.
You pay better than regular Medi-Cal because you're still Medi-Cal.
I'm still Medi-Cal.
But you're taking all those Medi-Cal dollars in. Now here's the thing that the big threat with this Senate bill, the Senate healthcare bill, as we know it now, they keep wanting to change. They're going to want to change it, but the broad outlines are about almost $780 billion they want to cut.
Yeah.
They're trying to, there's I think a little bit of deception here because they're trying to disguise those cuts by not letting them be implemented immediately. But let's make no mistake about it. They're looking to cut back that 340,000 number of people on expanded Medicaid.
Yeah, they are.
And the rhetoric that gets out there is that they're making it sound as if these people are deadbeats, that they're not working. Why don't just get a job? But we know that 60% of these people have jobs, and that another 20% or so are looking for work, and that of that 40%, I mean, a big chunk of them have serious health conditions
can't work right now.
And can't work right now.
But if you get them in a better state of health, they might be able to work. So I think there's three things that are really difficult about the bills that have been presented.
Okay.
One is, by doing the per capita, they're going to cut the amount of money available for
per
Medicaid
capita. That's per capita is kind of a word that our folks might understand.
So they pay a certain amount per person per month, but they cap it so that if medical costs go up, if new drugs, new procedures, it doesn't keep pace with that. So that ends up being less money. The other thing they're doing is they're delinking essential health benefits from Medicaid. Well, that means then they might stop covering mental health. You raised the example, people with diabetes, with hypertension, they're depressed.
So
you've got to treat the whole person.
Let's talk a little bit more about essential health benefits. Essential health benefits, there's, I think, 10 of them described broadly. those 10 essential health. So look, the Affordable Care Act was not just about affordability, it was also about patient protection.
Yes.
And healthcare insurance is pretty complicated, long contract. And one way private insurers made money was to sell plans that wouldn't cover certain things. I mean, I sometimes think I'm going to try and buy, say, travel insurance, and then I find out that the reason why I missed the plane was not covered by that insurance. I'm not going to, and sometimes I think that travel insurance is kind of deceptive. Well, the same thing goes on with health insurance. It went on in a big way before the ACA, and that's why they try to set a standard with the ACA that nobody could be sold an insurance plan that didn't cover these 10 areas. And so these 10 essential health benefits are pretty important for that patient.
And they're pretty basic. I mean, they're outpatient care, inpatient care, medications, mental health treatment, substance abuse treatment. So if you de-link, to your point, suddenly Medi-Cal patients might not have access to mental health services. Well, that's not going to work, because often there's a behavioral health, I'm depressed and I have diabetes. You got to work on them together. You only do one, it doesn't work.
So the third thing, so we mentioned two things so far, so the essential health
benefits. Third thing is then the real reduction in expansion eligibility, is really cutting back the dollars so severely for the expansion population that the states can't cover them. I mean, they're not able to cover them. So then you truly lose eligibility, then you're no longer covered at all. So it's overall dollars available through per capita, controlling it, the essential health benefits, and then this real cutback on expansion. So those 340,000 people currently covered, I think get put at risk.
Well, and let's be also clear that expanded Medicaid, expanded Medi-Cal was paid for in the ACA, was paid for through a series of taxes, medical devices. People don't like taxes, but there was a 3% tax on people with investment income, people who earn $250,000 or more. And let's be clear that the tax cuts that are being proposed, the taxes they want to cut, are not for middle class people necessarily. I suppose there are some people who earn $255,000 who consider themselves middle class, and I get that. But in general, we're talking that the bulk of the American population, they're not seeing incomes of $250,000. I think call it what it is. People in the upper income levels, the very wealthy, are going to see under the Senate bill a tax cut. A 3% on investment income. People who are this is not necessarily sweat of the brow sort of. It's money that's earned on investments. That's going to be cut in order to throw lots of people off of.
Yeah. So I don't have the expertise around taxes.
Okay, I'm not going to get you.
But here's how I look at it. You pay for it one way or another.
Yeah.
If you don't cover people, they get sicker, they show up in the emergency room, that hospital doesn't get paid, the doctor doesn't get paid, and we all end up paying for it one way or another. And as you said, the worst place to get regular care is in an emergency department. You get bills of $2,000 to $5,000 that could be covered by a $150 visit to a doctor.
Well, I think a big takeaway here is what's at stake for Riverside and San Bernardino. What's at stake for us here is 1/4 of our population is on Medi-Cal. That's where they're getting the health insurance. 300, about 1/4 of that population is on expanded Medicaid or Medi-Cal. I agree with you. I think we're far better off helping these people, 60% of whom are actually working. And it's astounding to know that we have a lot of people working, but they're earning $8 an hour, or they're earning.
Or they get no coverage from their employer.
So their employers aren't covered. Right. So they may be working for an employer who has 50 or less people currently. Under the ACA, if you have 50 or more employees, you're required to offer coverage.
Or they're part-time.
So they may be part-time. So there's all sorts of reasons why they may not have employer-based coverage. Right. That's a lot of people who are working who would not have health coverage. And it seems to me that long term our economy is going to benefit if we keep people healthy. They can get job training or more education. We can stabilize the people who have chronic health conditions so that they can actually, I think, be more motivated to get work.
I mean, the alternative is they become fully disabled, so they cannot work. I mean, they get to a point within their chronic illness, or diabetes, hypertension, or heart disease, where they're unable to work going forward. So then you've lost that person ever being a productive member of society.
So so by neglect or indifference, they get get on a path toward disability
Or
that
no
will
coverage,
qualify. And as you said, disability has become harder and harder.
Yes.
Social Security disability, or
Yes.
the levels of disability have become harder to qualify for, and it shouldn't necessarily be easy to get
Full-time disability.
It
So
shouldn't
that's
be easy.
why it's so important to be able to do the preventive care, and control those chronic illnesses so that people can be as healthy as they can be. They can work, they can pay taxes, and support us. Because the alternative is high, expensive care and really a person not doing well physically and mentally.
So what I see in this Senate bill is that they want to take away any revenues that will help pay for caring for a large part of our population, and then that's going to really benefit people who earn $250,000 or above. I see them wanting to repeal the employer mandate that requires employers with over 50 employees to offer insurance. They want to take away the essential health benefits, allow states to not necessarily, and they're very basic health benefits.
And delink it from Medicaid.
And delink it from Medicaid. So people who actually have insurance now under employer, the employer is no longer going to be required to sell them insurance. The product, the insurance products that will be available to them in the future could be more narrow because they're taking away the consumer patient protection. So that's going to happen on one sector of our labor market. On the labor market that's really struggling, no health care means that they're going to be going to the emergency rooms, making it very, very unstable for the hospitals economically. That hurts those of us who are in the.
It's a bad cycle.
So it's an unvirtuous cycle, right? It's going to hurt us.
Yeah.
So, well, Doctor, is there anything else you want to get across?
I mean, I think what's really important is people need. I'm a physician. I'm a doctor.
Yeah.
People need health care. They need to be as healthy as they can be to be part of life and to live their life in a positive way, including working, including being able to be with their family. So I see it very simple, that we need to provide people coverage, either through their employers, but if that's not an option and they're low income, then Medicaid has been an answer. So why go back to when, as you said, insurance plans were complicated, you couldn't figure out how you were covered, and having hundreds of thousands of people not covered. That doesn't do anybody any good. And as I said again, I'm going to say it again, we pay for it one way or another.
Well, thank you so much for your time.
You're welcome.
I hope
Pleasure.
I hope we've been able to clear up some of the there's a lot of misinformation.
A lot of misinformation.
And I think the big takeaways for me is that our Medicaid population here, most of them are working or trying to find work. It would be an economic disaster for many of our hospitals were this Senate bill to succeed as it is. The idea of putting 15 million people out of insurance in just 1 year is
very rough.
Is really rough.
Yeah.
And that $1 billion of federal money flows into our health care.
I feel like we just got the Inland Empire back on its feet. And if you pull $1 billion out of the economy, the health economy, jobs will be lost. People will lose jobs, and then we're back in the cycle of they lose jobs, but they can't get coverage. So you get into a worse cycle. It cannot be good for our economy to lose $1 billion. That's pure payments. That's not even the multiplier. And usually multiply by 1.5 to 2 times because of all the individuals that support physicians in hospitals, all the companies. So we're talking $1.5 to $2 billion. I don't think our economy can handle that.
Well,
but I'm not an economic expert. I'm just a doctor.
Well, Dr. Gilbert, thank you so much.
Yeah, thank you.
It's
really
been great.
appreciate
It's been
it.
great to
Really
be here.
appreciate
Thank
it.
you.
Yeah, thanks.